Hello everyone and welcome. I'm Dr. Asim Hussein and I'm excited to be here with you today. We will be discussing Platypnea-Orthodoxia Syndrome, or POS for short. In this presentation, we'll cover what POS is, its clinical features, how it's diagnosed, and the approaches to management. I look forward to sharing this information with you and exploring this interesting condition together. Let's get started. Let's take a closer look at this case. We have a 72-year-old man experiencing progressive shortness of breath over 3 months. What's interesting here is that his breathlessness gets worse when he's sitting or standing, but improves when lying flat. This positional change is a key point. On exam, his chest sounds are clear, and there are no signs indicating heart failure. His oxygen saturation is 96% when he's lying down, but drops significantly to 86% when he's sitting upright. That's a notable drop, indicating a positional hypoxemia. The chest X-ray appears normal, which rules out many lung pathologies, and the echocardiogram shows normal right-sided pressures, so no obvious signs of pulmonary hypertension or right heart strain. Putting all this together, the most likely diagnosis points toward a condition that causes oxygenation to worsen with upright positioning, but improve when lying flat. This pattern is classic for a phenomenon called Platypnea-Orthodeoxia Syndrome, often associated with a patent foramen ovale. This condition involves a right-to-left shunt that becomes more prominent when upright, leading to hypoxemia. It's important to recognize because it can be mistaken for other causes of hypoxemia, but the positional nature is a distinguishing feature. So, in summary, based on these findings, the most probable underlying diagnosis here is a patent foramen ovale. Now let's discuss why the other options are incorrect. Starting with option A, a pulmonary embolism typically causes hypoxemia that is not dependent on posture. So, if the oxygen levels drop only when upright, a PE wouldn't be the first suspect. Moving to option B, heart failure with preserved ejection fraction, or HFpF, usually causes orthopnea, difficulty breathing when lying flat, but it doesn't typically cause platypnea, which is shortness of breath specifically when upright. Option D, COPD, leads to chronic hypoxia, but it doesn't have a characteristic pattern of desaturation that depends on body position. And for option E, obesity hypoventilation syndrome, or OHS, tends to worsen when lying down, so desaturation is worse in the supine position, not upright. So the correct answer here is C, a patent foramen ovale. This condition is often associated with the syndrome of platypnea and orthodoxia, meaning shortness of breath and oxygen desaturation that occur when upright. The key point is that a PFO can create a right-to-left shunt inside the heart, even if pulmonary pressures are normal. When someone moves to an upright position, changes in atrial geometry or venous flow can promote this shunting, leading to decreased oxygen levels and increased breathlessness. It's a classic presentation that we should keep in mind, especially because the mechanism involves intracardiac shunting rather than lung pathology. Understanding this helps us recognize that not all hypoxemia is lung-related. Sometimes the heart's anatomy plays a crucial role. Let's take a closer look at this case. We have a 70-year-old man experiencing progressive dyspnea, which gets worse when he's sitting upright and improves when lying flat. This positional change is a key clue. His pulse oximetry shows a drop from 95% when supine to 85% when sitting. That suggests some form of orthopnea or positional hypoxemia. Interestingly, his chest X-ray and spirometry are normal, and his echocardiogram shows normal biventricular function with no pulmonary hypertension. So, typical lung and heart issues seem less likely. Given these findings, the next best step is to look for a cause that explains the positional hypoxemia without clear lung or heart pathology. We need an investigation that can detect intracardiac shunts or abnormal blood flow that might cause this pattern. Among the options, bubble contrast transthoracic echocardiography is particularly suited for this. It can identify a right-to-left shunt, such as a patent foramen ovale, which might become significant when changing positions. So, in summary, this case highlights the importance of considering intracardiac shunts or other sources of right-to-left shunting in patients with positional hypoxemia, especially when initial tests are normal. And this is why bubble contrast echocardiography is the most appropriate next investigation here. The correct answer here is C, bubble contrast transthoracic echocardiography. Now, let's break down why this is so important. Positional hypoxemia, which is a drop in oxygen levels when the patient changes position, strongly suggests a condition called Platypnea-Orthodeoxia Syndrome. This syndrome involves abnormal blood flow that worsens when the patient is upright. Bubble contrast echocardiography is considered the first-line test in these cases. It's a non-invasive way to detect a right-to-left shunt, which is essentially a pathway allowing blood to bypass the lungs and go directly from the right side to the left side of the heart. Identifying this shunt is crucial because it explains the hypoxemia. Once we confirm the presence of a shunt with this test, more invasive or radiation-based tests can be used if needed. But initially, bubble contrast echocardiography provides a safe, effective, and straightforward way to diagnose the problem. This approach aligns with our overall goal of accurately detecting and managing conditions that affect oxygenation in patients. Now let's take a closer look at this scenario. We have a 68-year-old woman who has confirmed orthodoxia, which is a drop in oxygen saturation when she moves to an upright position. The bubble contrast transthoracic echocardiography shows bubbles appearing early in the left atrium, suggesting a right-to-left shunt. The key here is to identify the most appropriate next step to define the underlying abnormality. Since the echocardiogram indicates a shunt, we need an imaging modality that can precisely locate and characterize it. Looking at our options, high-resolution CT chest can give us detailed lung imaging, but isn't the best for detecting intracardiac shunts. Transesophageal echocardiography offers better visualization of the atrial septum and can detect shunts more accurately, especially with bubble contrast. CT pulmonary angiography is excellent for pulmonary vessels and embolism detection, but not ideal for intracardiac shunt evaluation. Right heart catheterization is invasive and useful for hemodynamic assessment, but it's not the first step for anatomical diagnosis. And pulmonary function testing helps assess lung capacity and function, but doesn't identify shunts directly. Given all this, the most appropriate next step is B, transesophageal echocardiography. It provides a more detailed view of the atrial septum and can confirm the presence and nature of the shunt, guiding further management. This approach aligns with our goal of pinpointing the underlying abnormality effectively and safely. All right, so the correct answer here is B, transesophageal echocardiography, or T. Now, why is that the best choice? Well, early bubbles seen during the test actually indicate an intracardiac shunt. This is important because it helps us identify abnormal blood flow between the heart chambers. T is considered the gold standard for visualizing the heart's anatomy in these cases. It provides a detailed and clear picture, which is crucial for accurate diagnosis and planning treatment. So, overall, when we're looking for intracardiac shunts, T is our most reliable tool because of its superior imaging capabilities. Let's look at this case of a 74-year-old man presenting with Platypnea-Orthodeoxia Syndrome. As you can see from the echocardiogram, he has a large patent foramen ovale, or PFO, which is significant here. Interestingly, his pulmonary artery pressures are normal, so pulmonary hypertension isn't contributing to his symptoms. Despite that, he's still experiencing considerable symptoms, which suggests a shunt at the atrial level. When we think about management, it's important to remember that the key issue is the PFO acting as a right-to-left shunt, causing oxygen desaturation, especially when upright. The most appropriate definitive treatment in this scenario is percutaneous PFO closure. This procedure directly targets the anatomical defect, effectively reducing the shunting and alleviating symptoms. Other options like long-term oxygen therapy or diuretics don't address the underlying shunt. Anticoagulation alone is also not sufficient here, since the problem isn't primarily related to clot formation. Pulmonary vasodilator therapy wouldn't be effective because pulmonary pressures are normal, and vasodilators are more useful in pulmonary hypertension scenarios. So, in summary, for a patient like this, with a significant PFO and symptoms related to shunting, percutaneous PFO closure is the most definitive and appropriate management. The correct answer here is E, percutaneous PFO closure. When we're dealing with a symptomatic patent foramen ovale, or PFO, the best treatment option is actually closing the defect. This approach usually leads to a quick resolution of hypoxemia, which is great because it addresses the root cause directly. While oxygen therapy can provide some support and help improve oxygen levels temporarily, it's not a definitive solution. It doesn't fix the underlying problem, it just helps manage the symptoms in the short term. So, to connect this to the overall theme, understanding the appropriate intervention for PFO is crucial because it can significantly improve patient outcomes, especially when hypoxemia is involved. Closing the PFO percutaneously offers a targeted, effective treatment that can rapidly restore proper oxygenation. Let's take a closer look at the definition of Platypnea-Orthodeoxia Syndrome. This is a rare condition, but understanding it is important. It is characterized by two main features. First, there's platypnea, which means the patient experiences shortness of breath that worsens when they are in an upright position, like sitting or standing. Interestingly, this improves when they lie down. Second, there's orthodoxia, which refers to a drop in arterial oxygen saturation, specifically a decrease of at least 5% or 4 mmHg in PaO2 when sitting or standing. This reduction also gets better when the patient is lying down. Connecting these points, the syndrome essentially involves a positional change that impacts oxygenation and breathing. Recognizing these key features helps us understand the underlying mechanisms and guides us in diagnosing and managing this rare but significant condition. Throughout this presentation, we're emphasizing how positional changes can dramatically influence respiratory and oxygenation status, which is central to the overall theme of patient assessment and tailored management. Let's take a closer look at the core pathophysiology behind POS. Essentially, it results from a position-dependent right-to-left shunting or a severe mismatch between ventilation and perfusion, known as VQ mismatch. It's important to note that this happens without primary pulmonary hypertension being involved. Usually, two main components are needed for this to occur. First, there's an anatomical defect that allows for shunting, so a structural issue that creates a pathway for blood to bypass the lungs. Second, there's a functional or postural factor, something that promotes or worsens the shunt when the patient is in an upright position. This combination explains why symptoms like platypnea and orthodoxia happen. They're linked to changes in posture. When the patient moves to an upright position, these factors promote the shunt, leading to decreased oxygenation. Understanding these mechanisms helps us see how POS is a complex interplay between structural abnormalities and positional influences, highlighting why the symptoms are so dependent on posture. This connection is essential as we consider diagnosis and management strategies for patients presenting with these unique features. Now, let's take a look at the intrapulmonary causes of hypoxemia. These include pulmonary arteriovenous malformations, or PAVMs, which are abnormal connections between arteries and veins in the lungs. Then there's hepatopulmonary syndrome, a condition related to liver disease that affects oxygenation. Severe basal lung diseases like fibrosis or pneumonia can also contribute, especially because they impact ventilation at the lung bases. The key mechanism here is that, in an upright position, increased blood flow to these poorly ventilated lung bases can lead to hypoxemia. Moving on to intracardiac causes, which are actually the most common. Conditions like patent foramen ovale, or PFO, and atrial septal defect, ASD, fall into this category. There's also fenestrated atrial septum. The interesting part is how these defects behave with posture. When you stand up, the shape of the atria or the flow of venous blood can change, increasing a right-to-left shunt even if the pressures on the right side of the heart are normal. These intracardiac shunts are often associated with other conditions, such as a dilated aortic root, kyphoscoliosis, or after procedures like postpneumonectomy. Sometimes, an elevated diaphragm can also play a role. All of these causes are classified under the umbrella of conditions like Platypnea-Orthodeoxia Syndrome, or POS, which is characterized by shortness of breath and oxygen desaturation that worsens when sitting or standing up. Recognizing these mechanisms is crucial because they help us understand the underlying causes of positional hypoxemia and guide appropriate management. Let's talk about the clinical features of this condition. One key point is positional dyspnea, which means shortness of breath that worsens when sitting or standing. You might notice patients feeling more breathless when they're upright, but relief when lying flat. Along with that, there can be positional hypoxemia, where oxygen levels drop significantly in certain positions, and this can be documented through desaturation testing. Interestingly, on physical exam, the lung and cardiac assessments are often normal, which can sometimes make diagnosis tricky. The symptoms tend to improve when the patient lies flat, which is a helpful clue. Now, this constellation of features, particularly the positional nature of the symptoms, is characteristic of Platypnea-Orthodeoxia Syndrome, or POS. It's important to recognize this because it highlights how positional changes can directly impact oxygenation and breathing, and that understanding these features can guide us toward the correct diagnosis and management. Let's walk through the diagnostic approach for this condition. First, it's important to confirm orthodoxia, which is a decrease in oxygen saturation when moving from a supine to an upright position. We typically do this with pulse oximetry or arterial blood gases, comparing measurements in both positions. Next, we need to identify if there's a shunt involved. The standard initial test is a transthoracic echocardiogram with a bubble study. This helps us visualize abnormal blood flow. If more detailed evaluation is needed, we turn to transesophageal echocardiography, which is considered the gold standard, especially for detecting a patent foramen ovale or atrial septal defect. Beyond that, additional tests are performed based on what we find or suspect. For example, if pulmonary arteriovenous malformations are suspected, a CT pulmonary angiography is useful. Similarly, a contrast-enhanced CT of the chest can help identify other vascular abnormalities. In cases where hepatopulmonary syndrome might be involved, a liver ultrasound or contrast echocardiography can provide valuable information. And finally, we should keep in mind Platypnea-Orthodeoxia Syndrome, which is a rare condition where symptoms worsen upon sitting or standing, and it requires specific diagnostic consideration. Overall, this structured approach helps us systematically evaluate and pinpoint the underlying cause of the patient's symptoms, guiding us toward the most effective management. Now, when it comes to management, the key point to remember is that the definitive treatment really depends on the underlying cause of the condition. For example, if the issue is a patent foramen ovale or an atrial septal defect, the treatment options usually involve either percutaneous closure, which is minimally invasive, or surgical closure if needed. In cases of pulmonary arteriovenous malformations, embolization is the preferred approach to block the abnormal vessels. When we're dealing with hepatopulmonary syndrome, liver transplantation becomes the mainstay of treatment, as it addresses the root liver pathology contributing to the pulmonary issues. Supportive oxygen therapy can also play a critical role, especially as a temporary measure to improve oxygenation while definitive treatment is being planned or performed. And for Platypnea-Orthodeoxia Syndrome, which causes positional hypoxemia, management often includes addressing the underlying anatomical or physiological factors, but oxygen therapy can help alleviate symptoms in the short term. Overall, understanding the cause guides us toward the most effective management strategy, which ultimately improves patient outcomes. Now let's talk about the prognosis. The outlook is generally excellent, especially when the underlying cause is identified and effectively corrected. Once we address the root issue, patients often experience dramatic improvements, not only in symptoms but also in oxygenation levels, which can be quite remarkable after shunt closure. This brings us to a specific condition called Platypnea-Orthodeoxia Syndrome, or POS. It's a fascinating syndrome where patients experience shortness of breath and oxygen desaturation that worsen when they are upright and improve when lying down. Recognizing and understanding POS is crucial because, with proper diagnosis and treatment, the potential for a very good outcome is high. So, the key takeaway here is that early detection and targeted management can lead to significant and positive changes in patient health. Let's go over some key exam and clinical pearls for Platypnea-Orthodeoxia Syndrome, or POS. First, think of POS when you encounter unexplained hypoxemia that worsens when the patient is upright. This positional change is a hallmark feature. Second, remember that normal pulmonary pressures don't rule out an intracardiac shunt. Even if the pressures seem normal, a shunt can still be present and cause significant hypoxemia. Third, bubble echo is an essential diagnostic tool here. It helps visualize the right-to-left shunt more clearly and confirms the diagnosis. Next, an interesting point. Dyspnea relieved by lying flat is actually the opposite of orthopnea, which we typically associate with heart failure. In POS, the symptoms improve when the patient is supine. Finally, understanding the overall picture of POS is crucial. Recognizing these clinical features and utilizing the right diagnostic tools can lead to accurate diagnosis and proper management. This syndrome exemplifies how positional changes can dramatically impact oxygenation and underscores the importance of a thorough clinical assessment. Thank you so much for your attention today. I really appreciate your time and interest. This is the final slide, and I just want to take a moment to express my gratitude. Throughout this presentation, we've covered key ideas that I hope will inspire you and provide valuable insights. Remember, the concepts we've discussed are all connected by the overarching theme of continuous improvement and innovation. Your engagement and curiosity are what drive progress, so I encourage you to take these ideas forward. Again, thank you for being here and for your commitment to learning and growth. I look forward to seeing how you apply these concepts in your own work. Thanks once more, and have a great day.